All right. We're so glad to have a bunch of guest speakers from Stanford today talking about various research opportunities at Stanford. And our first off is Prerana. She is going to be talking about three different studies at Stanford that she's currently recruiting for. So take it away, Prerana.
Yes, thank you for the introduction. I'm Prerana. I'm a research assistant at the Human Motor Control and Neuromodulation Lab at Stanford. And as Robin mentioned, I'll be talking about a few different studies that we are actively recruiting for. So first, in thinking about Parkinson's disease as a whole, many patients struggle with seeing their doctor or neurologist at a frequent rate. Oftentimes, patients can only see their neurologist every 3 or 6 months, or even longer than that in between visits. And it can be very difficult for both the patient and the doctor to measure or monitor symptoms in the meantime between those visits. And so, a lot of times, disease monitoring is limited to just these subjective measurements during these in-person assessments that are not that frequent. And patients and caregivers are often left on their own to navigate these complex medication windows and day-to-day fluctuations that can be very tricky. And so our lab has a longstanding focus on brain and quantitative behavior research. And over the past 20 years, our principal investigator, Dr. Bronte-Stewart, has dedicated significant time to developing motor tasks that objectively quantify and study various aspects of Parkinson's disease. And so one such device that we've been working on is called Quantitative Digitography, or QDG for short. And the device itself is depicted in the middle here. It looks kind of like a piano or a set of piano keys. And we've also developed a mobile app and a web dashboard to go along with this device. And to expand a little bit more on this device, so the task that we've developed is called the QDG Mobility Task, and it's a 30-second task on this device involving alternating finger presses. So it would be like you were pressing on piano keys in an alternating fashion for about 30 seconds on each hand. And this task has been validated for all motor signs and symptoms in Parkinson's disease. So we are able to quantitatively gain metrics on things like bradykinesia, rigidity, tremor, even gait impairment. We have a mobile app that corresponds with the device that helps you guide or helps guide you through the task itself. And then the data from this task is then processed through our AI algorithm, which creates these validated metrics that are stored securely and analyzed and put into our dashboard. From there, your doctor or neurologist can create a personalized treatment plan that can help monitor and regulate your symptoms on a more timely scale. And so we're still working on validating some of the efficacy aspects of QDG in diverse case scenarios. And so we're recruiting participants for a few different studies involving the QDG device. We're looking for participants who are above the age of 18, diagnosed with Parkinson's disease or other neurological conditions, and are looking to perform testing either in clinic or at home settings, as well as answer some questionnaires related to the task and the key duo. A few different studies that we're recruiting for right now. So one such study is the home diary study, and here we're looking at participants or patients who experience motor fluctuations throughout the day or dyskinesias. And so a lot of people have varying medication doses throughout the day, and so sometimes they feel really on their medication, like it's working, and sometimes they feel really off, as in the medication isn't working very well. And so people who are fluctuating throughout the day would be a good candidate for this study, as well as people who have dyskinesias or wiggling, twitching, or jerking movements. The study involvement would include 2 tasks every 30 minutes. So that would be the 30-second mobility task on our QDG device, as well as filling out a motor symptom diary entry. And the participation would only be for 2 consecutive days so that we can get a good gauge of how those motor symptoms are fluctuating throughout the day.
And it's every 30 minutes for the hours that the people are awake.
Yes, so that would only be during the awake hours. depending on the patient's or participant's particular schedule, also allowing for a few breaks in between.
And does it matter if people are taking medications or not taking medications? Do you care?
So, most of the people are taking medications and are correspondingly fluctuating throughout the day. We're mostly interested in the actual symptom fluctuations throughout the day. So, the particular medication schedule or dosage isn't as important as long as the symptoms are the ones that are fluctuating.
Okay, thank you.
Thank you for asking the questions. A second study that we're recruiting for with our QDG device is our remote monitoring study, which aims to assess the feasibility of using the QDG system remotely to monitor motor symptoms over time and in response to therapy. And so this would involve testing at least once or more times a day for 30 days. And once again, the particular medication schedule is not as important, nor the particular symptom profile. We're mostly interested in assessing whether the QDG system itself can track the symptoms over a long period of time in the remote setting.
And can you explain what remote means here? So, is the QDG system itself in some other location, or is it just it's at your home, but it's talking to some other system someplace?
Yeah, that's a great question. So, our QDG system as a whole involves the device itself, as well as an iPad that contains the mobile app that helps guide you through the task. That entire system can be taken home, and the entire task can be completed at home um, by the patient themselves. And so for both of these studies, the participants would take the iPad and the QDG home and conduct each task on their own in the home setting.
Okay, so then what's the difference between the home diary and the remote? If
Yeah,
in both cases they're taking the QDG device and the iPad home.
yeah, they're named a little bit differently. I know one says home and the other says remote. The main difference between the two studies is the length of time of participation and how often they would be testing,
I
but
got it.
both, yeah, both
Okay.
are in the home setting.
Okay. All right. Great.
Yeah,
Thank
uh,
you.
thank you. Alrighty. The next study we're recruiting for is called the Stanford Parkinson's Research in Neuromodulation for Gait, or SPRING study for short. And this is a focus on how we are beginning to utilize adaptive deep brain stimulation for treating Parkinson's disease. So, deep brain stimulation is one of the available therapies for Parkinson's disease. And the system for deep brain stimulation, or DBS, involves three components. One is the internal pulse generator, or IPG, shown in the chest area here, as well as leads and electrodes shown up here in the brain. The leads are implanted within certain areas of the brain to alleviate disease symptoms, and the IPG produces electrical impulses that regulate abnormal signals related to symptoms. And by 2023, more than 160,000 people have had the DBS device implanted, and this number has only increased in the years since. Um, Very recently, in the last month, adaptive deep brain stimulation was recently approved by the FDA as a clinical therapy. And so I'm going to talk a little bit more about that and what we're trying to look at here. So, thinking about cardiac pacemakers, modern cardiac pacemakers are what we call closed loop systems. And so they can sense the heart's electrical rhythms and on demand become activated when the heart rate goes below a threshold. And this allows them to use an automated algorithm customized to the patient. Meanwhile, most modern deep brain stimulators are what we call open loop systems. And this means that the device constantly sends electrical signals, pulses of a fixed frequency, amplitude, and pulse width. And what our lab is trying to look at is advance this DBS neuromodulation technology so that it can sense and respond to the brain's electrical rhythms and correspondingly adjust the stimulation that they are delivering to the patient, which can better be tailored to the particular symptoms of the patient. And this is what adaptive deep brain stimulation is. And so, one prominent symptom of Parkinson's disease that we look at is gait dysfunction or impairment. And here you can see an example of a patient with freezing of gait. They're experiencing a freezing episode while turning. And this symptom is known to be not well controlled by optimal medical therapy, which is typical Parkinsonian medications. And so, our research is exploring whether deep brain stimulation can be a better therapy for symptoms like this. And so the specific aims of this study is assessing whether this adaptive deep brain stimulation technology is feasible using a variety of different control policy algorithms, as well as the safety and tolerability of adding subject-specific medications along with the deep brain stimulation. And so for this particular study, we are working with patients who are already implanted with or are intending to be implanted with the Medtronic Percept PC or RC systems as part of their Parkinson's disease treatment. Percept is a commercially available FDA-approved DBS system. And over here, this shows the interface that allows us to record the neural signals. And so if your primary care doctor or neurologist is within Stanford, we can work in collaboration with your neurologist regarding your potential involvement in this study. The protocol for this study involves a few different visits. So we have an initial tech check to determine study eligibility. From then on, we have two primary visits. One involving our stepping in place task, which involves about a minute of stepping in place in one of our machines. And then we also have a turning and barrier course, as depicted in the picture here. It's somewhat like an obstacle course where a participant walks through the course, and it often elicits symptoms like freezing of gait, as shown in the previous video. After the visits in clinic, we have a long-term follow-up phase where we have the participants go home and assess their ability and symptoms on these on the deep brain stimulation over a 3 to 6 month interval following their clinic visits. And this helps us determine whether or not this would be a feasible technology in a variety of different settings. Overall, we aim to recruit participants who have gait impairment and or freezing of gait. But if you experience gait impairment but don't necessarily experience freezing, you may still be eligible for the study. Over here, we have some inclusion-exclusion criteria. But the primary symptoms that we're looking to target here is gait impairment.
And could you say again, Prerana, about you mentioned something about if your primary care physician is at Stanford, they can
Yeah.
make a referral, but it's not required that somebody have a primary care physician at Stanford, right? It could be anybody.
Yes,
Okay.
exactly. So if your primary care physician is outside of Stanford, our study doctors can work in collaboration with your local neurologist regarding the changes. So you don't have to be within the Stanford system. You can be referred from outside of Stanford as well.
Okay, great. Thank you.
Thank you. And then if you're interested in learning more, our study is funded by the NIH Brain Initiative UH3 grant, so you can find more details on clinicaltrials.gov with a little bit more detail.